So mesothelin is a cell surface glycoprotein that was discovered in our Hassan lab about 20 years ago. And I became involved with this work when I joined his lab as a fellow and have continued to do work on mesothelin. So we named the protein mesothelin because its expression on normal human tissues is limited to the mesothelial cells that line the pleura, peritoneum, and pericardium. It's a cell surface glycoprotein. It is made as a precursor protein of 71 kilodalton, which is attached to the cell membrane by GPI anchor, and it is cleaved by furin to yield a 31 kilodalton fragment called megakaryocyte potentiating factor because it has megakaryocyte potentiating activity in mouse bone marrow culture, and a membrane-bound 40 kilodalton fragment that we call mesothelin. We and others have shown that mesothelin is highly expressed in many cancers. Almost all epithelial mesotheliomas express mesothelin, as well as majority of pancreatic adenocarcinomas, 70% of ovarian cancer, as I discussed yesterday, about 50% of lung adenocarcinoma, but it's also highly expressed in other tumors, including gastric cancer, synovial sarcoma, triple-negative breast cancer, biliary cancer, and pediatric AML. So the therapies that we are developing targeting mesothelin have a wide implication for many different cancer types. So the high cell surface expression in many solid tumors makes it a good target for antibody-based therapies. Expression on the pleura, pericardium, and peritoneum was a concern when we decided to exploit it as a target for cancer therapy about 20 years ago. As I showed yesterday, this is one of the first studies which led us on this path. We wanted to see whether an antibody to mesothelin would localize to this tumor. So this was done with one of our original antibodies called K1, and these are athymic nude mice bearing mesothelin expressing cancer, showing specific uptake. And as I showed yesterday, we have done similar trial in patients and shown localization of anti-mesothelin antibodies in patients. So as you know, most monoclonal antibodies by themselves are not effective. There are some notable examples such as Herceptin or rituximab, which as single agents have activity. But to make antibodies effective for cancer therapy, there are other approaches that you could add highly potent effector molecules to the antibody. One approach is to conjugate the antibody to protein toxins. These are called immunotoxins. Another approach is to conjugate antibodies with highly active chemotherapy drugs. These are the antibody drug conjugate. And the third approach is to conjugate antibodies with radioisotopes. So these have shown promise in heme malignancies, but at the present time, they are not feasible for solid tumors because of bone marrow toxicity. So SS1P is an anti-mesothelin immunotoxin, which consists of an anti-mesothelin FV linked to a pseudomonas toxin developed in our Hassan lab. And studies in my lab show that it is cytotoxic to mesothelin-expressing cells from patients with mesothelioma as well as ovarian cancer. And we also show that it causes regression of mesothelin-positive tumors in mice. So about 15 years ago, I treated the first patient with SS1P when I was at University of Oklahoma. This was a patient with ovarian cancer, so this was the first time an anti-mesothelin agent went into the clinic. So we treated 34 patients on this study. We established the maximum tolerated dose, and the dose-limiting toxicity, as we expected, was pleuritis because it's present on normal pleural cells, but we did not see any pericarditis, which was very important. However, this was a negative trial because there was no anti-tumor activity. And the principal reason that it was a negative trial was that the drug was immunogenic. Most patients developed antibodies after just one cycle of therapy. Although it was a negative trial, it was a very important trial for us because it showed that you could therapeutically target mesothelin in patients, and that really spurred the development of anti-mesothelin therapies, and there are at least 9 or 10 therapies currently in the clinic. So the immunogenicity has been a big problem with immunotoxin. Almost every group has given up studying on immunotoxin because it has been felt that you cannot overcome this problem. So over the last 5-6 years, we have taken a couple of different approaches to overcome this problem. One is to prevent the development of human immune response to immunotoxin. and the other one is to modify the toxin so that it is inherently less immunogenic. As I showed yesterday, in our preclinical studies, we showed that the regimen of pentostatin and Cytoxan can completely get rid of immune response in immunocompetent mice. So we decided to do a very small proof of concept study doing exactly what we did in mice and do a small clinical trial in patients. So the patients who were enrolled in this trial were patients with treatment refractory and progressive mesothelioma. And the goal of the study was to see if it is really safe and feasible to do this. And the primary objective of this trial was to see if we can decrease antibodies to SS1P. So the trial design was very similar to the mouse study. You give the patients oral Cytoxan for about 12 days, give 3 doses of Cytoxan, and then you come up with SS1P. And in subsequent cycle, you give a smaller dose of the drugs. So to our surprise, the results of this study showed that using pentostatin and Cytoxan, you can greatly decrease antibodies to SS1P. If you give SS1P alone, 90% of the patients develop antibodies after one cycle, whereas with pentostatin and Cytoxan, only 20% developed antibodies after one cycle. And what was even surprising was that we saw some durable tumor responses in 3 out of the 10 treatment refractory patients lasting more than a couple of years, and one of the patients is almost 5 years out. So this was one of my patients who had a widely metastatic peritoneal mesothelioma. You can see bulky supraclavicular node, which went down with after just 2 cycles of therapy. And this is the same patient, extensive disease in the chest, abdomen, and pelvis. This is at 1.6 months showing dramatic reduction, and this is at 8 months. The patient died at 2.5 years from an unrelated infection. This is one of my recent patients with mesothelioma who had a very rare type of mesothelioma, which had spread from the chest all the way to the abdomen to the scrotum. And after 2 cycles, you can see significant improvement on PET activity. So this is very good, and so we were very excited as a proof of concept that you can get responses with immunotoxin, but it would be better to develop drugs where you don't need pentostatin and Cytoxan and make it less easy. So this is work done over the last 3-4 years, principally work done by Ronit Mazur and Masnuri Onda in Ara Paston's lab, and in collaboration with Roche, we made less immunogenic immunotoxins. I won't go into the detail, but basically the Pseudomonas toxin has been mutated, so we have removed all B cell epitopes and T cell epitopes, and the antigenicity is reduced about 1,000-fold, and it has significant in vitro and in vivo activity. This study is done in my lab by Jingli Zhang, using patient cells directly from patients with mesothelioma, showing that the activity of RG7787 is about 4 to 5 times more than SS1P. This is a tumor xenograph experiment using cells from patients where we combined RG7787 with nab-paclitaxel. Although nab-paclitaxel is not used in mesothelioma, and a cooperative group trial done about 15 years ago of Taxol showed no activity in mesothelioma, in our preclinical studies, we have seen significant activity of nab-paclitaxel, both in vitro and in vivo. And when we combine the immunotoxin with nab-paclitaxel, you get complete tumor regressions, which are long-lasting. So we have published many papers showing synergy between Taxol and immunotoxins, and we're trying to study the mechanism of this dramatic synergy. Just as a side note, Christine Allewine, who is an associate investigator in our program, is about to start a clinical trial of this combination in pancreatic cancer. So just to summarize our work on anti-mesothelin immunotoxin, I think we have shown proof of concept that SS1P with pentostatin and Cytoxan can cause tumor regressions, and this potentially less immunogenic immunotoxin will be evaluated in phase 1 trial, and we hope to open it in January or February this year. So that's good. However, there are other approaches besides immunotoxins to target mesothelin, which are also promising and in various stages of clinical development. I'll just talk briefly about amiloximab, also called MORAb-009. So amitaximab is a chimeric antibody to mesothelin that we developed in collaboration with Morphotek, and we have led its preclinical development all the way to phase 2 trials. So we have shown that it kills mesothelin-expressing cells by ADCC. We also demonstrated safety in a phase 1 trial, and in a phase 2 non-randomized trial, we showed that the combination results in improved survival. To demonstrate that in a phase 3 trial, a study of amitaximab with pemetrexed and cisplatin had just opened. So this is for patients with previously untreated epithelial mesothelioma, and they will be randomized 1-to-1 to PEM-CIS, which is the current standard of therapy with amitaximab, or to PEM-CIS alone, and the primary endpoint is overall survival. So we're very excited that the work we did in the lab has gone all the way to phase 3, and the first patient of this study was enrolled about a couple of weeks ago. Another approach to target mesothelin is the use of antibody-drug conjugate. Anitumumab ramucirumab is an antibody-drug conjugate developed by scientists at Bayer, which consists of an anti-mesothelin IgG1 linked to the metastenoid derivative DM4. As you know, DM4 is a tubulin inhibitor and kills tumor cells expressing mesothelin and showed activity in preclinical models. So we have been doing a phase 1 clinical trial of amitaximab, and there are other investigators in this room who have participated in the study, and I presented it at the World Lung Conference a couple of months ago. And I just want to highlight a couple of points. So we established the MTD of this drug as 6.5 milligrams per kilogram given every 3 weeks. I would like you to focus on this column. These are the mesothelioma patients treated at MTD. Out of the 16 patients who were treated at MTD, 31%, 5 out of the 16 had durable partial response. However, if you look at the patients who got anitumumab as second-line therapy, half of them had a confirmed partial response, and overall 90% had disease stabilization. And just to show you that these responses were durable, these are 3 patients who are still on the study, and the response duration is 2.5 years in these 3 patients. And as you can see, stable disease about 6 months. So in these patient population, we feel getting a response duration of about 2 years, 2.5 years is pretty good. So based on these results, this trial is going to a phase 2 registration trial in second-line setting in mesothelioma, and we hope to have it open at NCI in a couple of months. The fourth approach that we have been working on a long time is targeting mesothelin-expressing cancers using a mesothelin vaccine. So this is work done many years ago by folks at Aduro, Doug Brockstead, and Tom Dubinsky, who have a new platform for cancer vaccination using Listeria monocytogenes. As you know, Listeria is a bacteria, and what they did is they modified the bacteria, so they got rid of the 2 virulence genes and replaced that with mesothelin, and so that it is stably expressed in the Listeria. And we showed in a phase 1 trial along with other folks that it was safe. And we also showed that it induces mesothelin-specific immunity in patients with mesothelioma. So based on this phase 1 clinical trial, about 3 years ago, we designed a phase 1b clinical trial with Aduro. So in this schema, we give patients 2 doses of the vaccine 2 weeks apart. Then we give 4 to 6 cycles of chemotherapy. And after that, we give boost vaccination. And the primary goal when we started this study about 3 years ago was to show its safety and look at induction of mesothelin-specific response. And I presented the results of this study on behalf of other co-authors at ASCO earlier this year. And this is a summary slide showing the best overall response in these patients. So these are patients who get the vaccine along with PEM-CIS, and 59% of the patients have confirmed partial response, and some of the patients also who have stable disease have tumor shrinkage. This is a spider plot showing that many of the responses are durable. And we have also done pre and post biopsies on the patients we treated at NCI to look at changes in the tumor. And this is a summary of pre and post changes in 3 of the patients, showing an induction of CD8 cells. This is pre, this is post, showing increase in dendritic cell maturation, as well as increase in macrophages. So this is the first time we can show that you can induce both an adaptive immune response to this vaccine. And as I mentioned, a clinical trial of a similar vaccine just opened for treatment of lung adenocarcinoma, so we're very excited about that. So this is my last slide. I know I talked about many different agents, so I just want to put them in context where they are. So chimeric antibody to mesothelin called ematuximab that we developed in collaboration with Morphotek is right now in phase 3 frontline study. So it is comparing this with PEMSIS versus PEMSIS alone. So first patient was enrolled about 2 weeks ago. SS1P was our first generation immunotoxin, which shows proof of concept activity. We still have this trial open, but as soon as we open the less immunogenic immunotoxin, we'll close the SS1P. So we'll be doing a phase 1/2 trial initially in mesothelioma. The antibody drug conjugate called enitumumab is about to enter a phase 2 registration trial in second-line therapy of pleural mesothelioma. And the listeria vaccine that I talked about, it was a phase 1b trial, but it's about to open as a phase 3 registration frontline study comparing CRS-207 plus PEMSIS versus PEMSIS alone. So we're very excited that 2 of these drugs are entering phase 3 trials in mesothelioma. This one is phase 2, and we're also excited over the lung adenocarcinoma trial. And lastly, this work has been possible over many years with a lot of collaboration, members from my clinical and lab, as well as long-term collaboration with IRA and my collaborators within the NCI, as well as long-term collaborations with many of our pharmaceutical partners who have helped develop some of these drugs. Thank you.
So, Raffit, very nice. Very impressive, really, for mesothelioma. This is great. So the antibody drug conjugate, enitumumab and Raffit Hassan, how did you determine the phase 2 dose? What was the toxicity in phase 1 that?
Oh yeah, sorry, I didn't. That? Sure. So the toxicity that we anticipated, there were 2 toxicities that we anticipated from them. One was peripheral neuropathy, because it is basically a taxane. And the second toxicity that we anticipated was corneal epitheliomopathy, that patients might get diminution in vision. And that is thought to be because the toxophore, the DM4 deposits in the cornea. And so these patients in the phase 1 trial were getting regular ophthalmologic examination at different interval. So the dose limiting toxicity at 7.5 milligrams per kilogram was patients had decreased visual acuity and corneal deposit, which was reversible in every patient. It came down. But that is a toxicity which is in the doses that we will use in the phase 2 is usually grade 1 and 2, and it results by stopping the drug maybe for a week or so and then coming back. And we have also learned that using topical steroid help. So.
One quick question on your choice of using an immunotoxin versus a toxin, or not, but why? Because there's obviously the challenges of using an immunotoxin. So what was your really kind of thoughts on that? Is it just because you may need less drug to get there, or what's your kind of thoughts on why you?
I think we believe in having different options and then see what works. So when we started this work, there was a lot of skepticism whether you can target mesothelin. So we had our lab works on immunotoxins, so we started with that. But it looks immunotoxins have disadvantages of immunogenicity, but they also have a very big advantage. is that they act by a very unique mechanism by inhibiting protein synthesis. So they're usually useful in patients who have drug-resistant disease. As you can see, some of the responses we saw were in patients who had got 3, 4 lines of treatment. So they would be useful in treatment refractory patients and hopefully in combination with taxane early on. So, okay, so if that is